Now coming to the disorders of esophagus, that is the first one what we are going to discuss is gastroesophageal reflux diseases. Gastroesophageal reflux disease. So what is gastroesophageal reflux disease? It's a very common disease, no, and many of us have suffered at some point in our lifetime, especially if you are doing your residency, or if you are doing if you are studying, no, for your entrance, no, you may end up having gastroesophageal reflux disease. So it is a condition that develops when there is reflux of stomach contents, and it causes troublesome symptoms and complications. So what will happen is the stomach contents will reflux into the esophagus, okay, and then it starts causing some symptoms, troublesome symptoms or complications, and that is a Montreal definition of gastroesophageal reflux disease, GERD, okay, and somewhere it is GORD, okay. So like esophagus can be spelled as like this or like this, so that is basically, you know, how E and O are different, okay, but it all means the same. So what is the etiology? Generally the reflux is avoided, okay, because of the reflux barrier, and also because there is a pressure difference between the abdominal cavity and the thoracic cavity. If this is disrupted, then the patient may have gastroesophageal reflux disease, the disruption of this, okay. So what are the reflux barriers, okay? So one we have is a diaphragmatic crura, and when there is a lower esophageal sphincter, okay. So we know that esophagus enters through the diaphragm, okay, and then there is like diaphragmatic crura here, okay. So if this is called as hiatus, no, so hiatus is more than 3 centimeter, okay. The crura are separate, little bit away from each other, and the hiatus size, no, is more than 3, okay, then 3 centimeter, then it will cause reflux barrier dysfunction. And we also know there is a physiological sphincter, no, lower esophageal sphincter. So we studied in manometry also now. So if there is any dysfunction in the lower esophageal sphincter, then it will cause reflux barrier dysfunction, okay. What happens is, no, whenever we during routine activities, no, we swallow some air, okay, and then there is a mechanism in the body, no, so you belch sometimes, like a lot of small kids, no, you burp them. So it's like in adult also we sometimes belch, though that is facilitated by this transient LOS relaxations. So okay, and if these relaxations happen very frequently, then the gastric secretions are going to reflux into the esophagus. The other thing is, whenever there is acid reflux in the esophagus, generally it gets cleared, but in patients, no, for example, who has motility disorders of esophagus, okay, the clearance is not happening, okay, there is delayed clearance in the reflux secretions, or that's when you will have gastroesophageal reflux disease. Hiatus hernia, okay, many of the patient will have hiatus hernia. So what is hiatus hernia is, like this is the diaphragm, and then this is the esophagus, okay. So through the hiatus things are going to go up, okay, the migration of gastroesophageal junction upwards, okay. So that's when you are going to have hiatus hernia, and then it will predispose to GERD. And there are some acid pockets, no, whenever, if you see stomach closely, okay, so whenever you eat something, no, so there is all the food particles here, and there are some acid pockets here, okay, they are not neutralized, right. So if these acid pockets, no, if they are not neutralized, no, then they will cause gastroesophageal reflux disorder. So what is the global trend of gastroesophageal reflux disorder? If you look at the data from US or Europe, okay, up to 33% of the patients, of the people, general population is having gastroesophageal reflux disease. What are the risk factors? Risk factors for gastroesophageal reflux disease, that's obesity, smoking, okay, then lifestyle. These are the risk factors, and we know that gastroesophageal reflux disease is closely associated with cancer. So what will happen is GERD, okay, and some of these patients will have Barrett's, and then these patients may end up having adenocarcinoma. So there is a risk of cancer. So in West, no, ADC is one of the most common cancer, adenocarcinoma of the lower end of esophagus. That is because of higher incidence of GERD. The other thing we need to know is H. pylori infection. H. pylori infection is protective for this, because H. pylori infection, this one causes atrophic gastritis, and then the acid secretion is less. So that's why it is protective for ADC. What are the clinical features in these patients of GERD? Heartburn, most common symptom. They will ask you most common symptom of gastroesophageal reflux disease, that is heartburn. Patient will have regurgitation or water burst, no? So what, like you had a heavy meal and after some time you feel something is coming up into the mouth. So then you also have epigastric pain. Advanced diseases will have dysphagia. Okay, if there is a large hiatal hernia, no, then you can have dysphagia, and bleeding also is common. No, so there is something called as Cameron ulcers, that they are the ulcers which happen at the junction of esophagus and stomach in these patients. Okay, there may be single or multiple, and it can present as hematemesis. Okay, you need to know that, associated with hiatal hernia at G junction. This also happen in G junction. What are the extra esophageal symptoms? Okay, so they are basically symptoms related to throat or respiratory tract. Patient can have dental erosion, sinusitis, pharyngitis, laryngitis, recurrent otitis media, asthma, and pulmonary fibrosis. So these are the extra esophageal symptoms associated with gastroesophageal reflux disease. How do you diagnose? Any patient with GERD comes to you, you are going to put them on PPIs, like for example, even many of you had symptoms of GERD or reflux. You take just some PPIs and then you feel better within few days. Okay, so whenever patient comes to you, generally put them on proton pump inhibitors, and it is diagnostic also. If the patient beautifully responds to this, then probably it is GERD. Okay, upper GI endoscopy is the most common investigation done. Any patient who comes with GERD symptoms, if they are not responding to PPI, or sometimes you really want to know before starting the patient on PPI, you are going to do upper GI endoscopy. Okay, and that's how it look. Okay, this is LA grade C. I am going to talk about how you grade GERD in the next slide. pH monitoring, this is gold standard. What is the gold standard investigation for GERD is pH monitoring. I just told you about that. High resolution manometry, because sometimes the patient can have associated disorders. I remember there was a medical student who had dysphagia. Okay, and then initially it was diagnosed as achalasia, and then the patient was planned for POEM procedure, but we got high resolution manometry in this patient, and then it revealed that the patient is having GERD, severe GERD. It is not achalasia. So if you are done thinking that is achalasia, if you are done POEM, then the symptoms would have exaggerated. So like that, this will also help. Okay, and then if you are planning surgery for this patient, GERD patient, so you have to investigate thoroughly this patient, pH monitoring and high resolution manometry. Barium studies, previously we used to do this, now it's not of much use, but it can be helpful in patients who have complications of GERD, or after surgery if the patient develops some complications, then barium studies may be useful. So I just showed you the picture of Los Angeles classification. So how do we classify this reflux esophagitis? It's classified grade A, grade B, grade C, and grade D. Okay, so what is grade A? There is one or more mucosal break. There is one or more mucosal break that is less than 5 mm. So you can see, the mucosal break is less than 5 mm. It doesn't extend, between the tops of two mucosal folds. What is grade B? Grade B, that is the breaks are more than 5 mm, but rest all things remain same. It does not extend between the tops of two mucosal folds. But in grade C, okay, here what's the difference is, the mucosal break is continuous between the tops of two mucosal folds. Okay, you can see here, the mucosal break is continuous between the tops of two mucosal folds, but it is less than 75% of the circumference. But if it is more than 75% of the circumference, then it is grade D. It is grade D. So this is the Los Angeles classification of reflux esophagitis. They may ask you as a MCQ. Okay, so how do you manage this patient of gastroesophageal reflux disease? All of us know what we do. So lifestyle modifications, so most of these patients, if you ask them very carefully, what are the triggers? So they will tell you, if I don't sleep well for a few days, if I have eaten spicy food, if I have taken carbonated beverages, or if they have taken coffee, tea too much, that's when patient will have that. So you have to advise them, lifestyle modifications. You tell them that avoid all these things which are trigger for GERD, okay. And then what happens is patient will have a heavy meal and then they go and sleep immediately, okay. Heavy dinner and then you go and sleep immediately, you will have reflux. So better to have early dinner and at least have 2 hours gap, okay. So that's the lifestyle modification. If the patient is obese, no, tell them to lose weight. So don't have very heavy meals, no. So those are the things. Don't, like, limit your coffee intake, limit your tea intake. No, these are the lifestyle modifications. In medical management, we all know PPIs, okay, and the PPI doesn't help. Then you add H2 receptor antagonist, or you can also add prokinetics. But using PPIs for long term are not good, though it has not been proven that they cause any harm, but it should not be used for a very long time, or if you are using it, then use it at the lowest possible dose. So that's about PPI use, no. Then there are some other favorite things. What we generally prescribe is the acid neutralizing, no, like alginate preparations, no? The syrups, no. So these preparations we generally give to the patient, okay. So they can be used. What are the alternative therapies? There are receptor modulation, no. Here you can use SSIs, no, and then hypnosis, behavioral therapy. So these are the other modalities. I'm just telling these things for academic interest, but we don't use them very often.